Hey guys, Miss Hill here, and we are going to continue with individual module 5.1. In this PowerPoint 5, we're talking about antepartum care and alterations that can occur in the antepartum period. We left off at preterm labor today in class, so that's where we're going to start from. Your learning outcomes are available in each of these 3 slides. And here we are. We're going to start with preterm labor. And preterm labor is something that happens with women after 20 weeks gestation, but before 37 weeks gestation. Sometimes preterm labor is able to be stopped, and sometimes it is not. But one thing that we do know is that lower birth weight babies tend to do not so good once they're born. So preventing preterm labor or catching it prior to it happening, being able to stop it, has a better outcome for the mom and the baby. So let's talk about signs and symptoms of preterm labor. These women may complain of abdominal cramping. They may complain of a low backache. They may complain of low abdominal pressure. They may end up with bleeding or a change in discharge. Your cervix is very vascular whenever you're pregnant. So if the cervix starts to change, it starts to dilate or efface, which means thin out, then you're probably going to start seeing a change in vaginal discharge. It may be mucousy and streaked with blood, and that may be what she comes in complaining with, and then we may find out that she is in preterm labor. So that's something to make sure that we teach women about, is a change in discharge is something important to keep in mind. These women may have a sense that they need to push down, and that comes from that low abdominal pressure. If they have a sensation that they need to push down, it could be an indication that delivery is getting ready to happen, that the cervix is opening up and the fetus is moving down into the vaginal canal. Contractions are another thing they may complain of, and intestinal cramping. When women go into labor, some of them will actually end up with nausea and vomiting symptoms. Some of them will end up with diarrhea, and so intestinal cramping can be something that they complain about. These things. Well, for our sort of first line of defense is making sure that mom is hydrated. So if we have somebody who is in preterm labor and it's very mild, we might just have her drink some water because maybe she's dehydrated, and that's what's irritated her uterus and caused these contractions to start happening. However, with more severe cases, we may actually have to start an IV and give her a bolus of LR. We may have to keep her on continuous IV fluids. And one thing hydration does for women is that it prevents the release of oxytocin. So our brain releases oxytocin as we start to contract or as we start to go into labor. And if you remember, we've talked about the things that oxytocin does, and one of those things is causes your uterus to contract. And it also causes the letdown of milk for individuals who are going to breastfeed as well. So, you know, one of the major actions causing contractions, we can prevent that by keeping ladies hydrated. So that's one reason why hydration, an IV bolus, drinking water is one of our first lines of defense. For women who have had preterm labor and they may be going home, they're being discharged from the hospital, or they've had a history of preterm labor, we might not want those ladies to be having any kind of sexual relations. So they may be on pelvic rest. They may be on bed rest because being up and walking around may stimulate contractions for them. So some of these individuals may actually have to be on bed rest for part of their pregnancy. If they have an infection that is causing the preterm labor, we need to know that. If it's a urinary tract infection, if it's a chlamydial infection or gonorrheal infection, we need to determine what kind of infection they have, if there is one, because we can do all the things we want to stop contractions, but if we don't identify the issue of why it's happening, the end goal will not work if we haven't gotten to the root of the problem. So if they have any kind of infection, we need to treat it. Tocolytics are the medications that are our first line of defense against preterm labor. We're going to talk about some of those in a second. Procardia and Indocin are our second line of medications that we use. So tocolytics are what we do first, and then if we can manage things with tocolytics, and maybe we're sending a lady home, but she continues to contract occasionally, then we may want to do something like put her on some Procardia to continue to take it home to keep those contractions at bay. So we don't use Procardia and Indocin as our first line of defense. We use the tocolytics first. Magnesium sulfate IV is also a possibility to stop preterm labor. And as we have discussed previously, magnesium is actually a smooth muscle relaxant. And we know that our uterus is a smooth muscle. So if we can relax that smooth muscle with mag, then we may have to put that mom on some magnesium sulfate. So this would be something that we would do if the mom was in the hospital and the tocolytics were not effective. So for preterm labor, magnesium sulfate is a last resort. Also, if you've got a mom who is in preterm labor, then we want to be preparing the fetus. If we know that delivery is gonna be happening and the cervix is dilating and we can't really stop that dilation, we want to prepare the baby. So we know that preterm infants or preterm fetuses do not have the lung capacity to exchange gas like they need to in extrauterine life, because they haven't developed the surfactants to be able to keep those alveoli open. And remember us talking about the LS ratio that we can test through amniocentesis. We know that lithiasin continues to increase throughout pregnancy and sphingomyelin stays the same. So we want that ratio to be at least 2 to 1 before we deliver somebody. One thing that we can do to sort of boost up that that lung maturity for a baby is give them some steroids. So betamethasone is usually what we use, and we give anywhere from 12 to 24 milligrams intramuscularly to the mom every 24 hours until she delivers. So this is going to be someone who we are certain is going to deliver within a certain period of time, within a few days, within a couple of weeks. This will be somebody whose contractions we really can't stop, and they've dilated to a point that they're probably going to be staying in the hospital until they deliver. So here is a little mnemonic about uterine relaxants or tocolytics. You can remember this by "it's not my time." So I stands for indomethacin, and that's an NSAID. N stands for nifedipine, which is a calcium channel blocker. And remember our whole discussion about calcium channel blockers and what they do. They help to block calcium from entering the cells and causing contractions or contractility. So that's why it works on the uterus. Magnesium sulfate, remember I said that was a sort of a last resort. We don't want to do that as our first line of defense. This is somebody who's going to be staying in the hospital and we cannot get her contractions stopped, will be the person that goes on MAG. Terbutaline is our first choice, okay? And terbutaline is also an asthma drug. There should be a terbutaline there. That's misspelled on this slide. So terbutaline is an asthma medication, and it also relaxes smooth muscles. But one thing that it does is it increases heart rate. So when we give terbutaline, we have to be certain that the mother's heart rate is not above 100. We need an apical pulse, and we need her on a monitor. So we need her on a continuous pulse ox so that we can continue to monitor her pulse whenever we give this. It's a sub-Q injection, and we need to educate her before we give it and let her know that it's going to make her feel anxious. It's going to make her feel probably a little weirded out. It'll make her feel like her heart's going to beat out of her chest, and that's okay as long as we prepare her for that, and as long as we don't give it if her heart rate is above 100. So we would never administer this to somebody who had a heart rate of greater than 100. Now, on the other hand, with things like magnesium, if we have given magnesium to a mom, it's going to make her feel very lethargic. It is going to decrease her blood pressure. She's going to feel just like she doesn't want to do anything. She's going to be very sleepy. And it's okay to tell her about that. It's also probably going to decrease her heart rate a little bit. And you may see changes in the fetal heart rate on the monitor as well whenever we give this to somebody. When people are in the hospital and we're using these type medications on them, we are continuously monitoring the baby. So we're not only concerned about what mom's heart rate's doing, how mom is feeling, but how is the baby reacting to those medications as well. So we got a bunch of things going on. If you've got somebody in preterm labor, we've got contractions happening. How is the baby looking in relation to the contractions? And I'm talking about heart rate, fetal heart rate tracing. And if we give some terbutaline and we increase mom's heart rate, what you should see is an increase in the baby's heart rate as well. And so we're looking for those types of things. This is a label of terbutaline, and it's a 1 milligram per ml injection that's given sub-Q. We do not use terbutaline for more than 72 hours. Like I said, it's a first-line drug, so a first-line defense drug against preterm labor, but we don't use it over and over and over again, partly because of the effects that it has on the mom. It causes tachycardia, and if you've got somebody who's tachycardic, then we're not pumping out everything that's in the heart because it's pumping so fast, so they become hypotensive. And then it can start to cause pulmonary edema, because if we're pumping the heart is pumping so hard that it's not pumping all of that fluid out, then where does it back up to? Well, it backs up still into the heart, and it'll end up backing up into the right ventricle, back into the pulmonary arteries, and then into the lungs, and then these moms end up with pulmonary edema. So it is very important for people who are on terbutaline, especially if we're using it for an extended period of time, meaning a couple of days, that we're assessing lung sounds, because we need to know, are they starting to back up into the lungs? It can also cause arrhythmias just because of what it does to the heart in terms of tachycardia. And like I said, it requires constant assessment and monitoring on the part of the nurse in terms of the maternal effects that it's having, but not just from a maternal standpoint. Remember, we have two patients, so we're also having to assess what is it doing to the fetus. So we've got mom on a continuous pulse ox, and we've got baby on continuous fetal heart rate monitoring. We only give a very, very small amount of this, so it comes in a vial, a 1 milliliter vial, and we only give a 0.25 milligrams. So we're pulling this up in a 1 ml syringe, and it's a really small amount. It's always important to have somebody check behind you when you draw it up, just like insulin. So what we hope happens at the end of all this is that dilation stops. So to actually be in labor, to call somebody in labor, they have to have changes in their cervix. So if somebody comes in and they say, I'm in preterm labor, well, they may be contracting, but if their cervix isn't changing, then we don't really call it labor. Just because somebody has contractions doesn't mean they're in labor. That cervix has to start to thin out or efface, and it has to start to dilate for us to be able to say they're in labor. So we hope that dilation stops. We hope that their bag of waters stays intact and does not rupture. We hope that they keep compliant with any kind of therapy that we put them on. So if they go home on a second line preterm labor defense like Procardia, we want to make sure that they continue to take that. If they go home on bed rest, we want to make sure that they're going to actually stay on bed rest. And ultimately, we want them to have a delivery at term, because the outcome we want is a healthy mom and a healthy baby. So let's move on to diabetes during pregnancy. We can have a bunch of different types of diabetes during pregnancy. Somebody can already be diabetic whenever they get pregnant. We can have type 1s and type 2s. People can end up with gestational diabetes, which means they are only diabetic because of the pregnancy. Those people are at higher risk for being type 2 diabetics after their pregnancy. And then we can have people who are already diabetics, and we just compound the issue with pregnancy. So during pregnancy, carbohydrate metabolism is affected greatly, partly because of hormones. But if you think back to what our metabolism does in the lecture of physiological changes, we change from like a glucose metabolizing cycle to lipids whenever we're pregnant, so that fats are readily available. So because of this, maternal insulin production increases, and so does our tissue response to insulin as well. And we end up with a buildup of glycogen stores in our liver and in other tissues because we need it. It needs to be readily available for the baby and for mom if she needs it. In the second half of pregnancy, we have a prolonged hyperglycemia and hyperinsulinemia after eating. Again, allowing things to be available for the mom and the baby. Moms also have a peripheral resistance to insulin that is increased greater than normal. The reasoning behind that is because if mom is resistant to the insulin that she's making, and she's making some overabundance of that, and she's also hyperglycemic, it allows the baby to have a better supply of glucose so that it can grow. And use that for its bodily functions. On the other hand, however, because the baby is using up all this glucose, the mom is not taking that glucose in. So whenever I said that they switch over to a fat metabolism, this is why. The baby is using up all the glucose that mom has, and then mom ends up in a catabolic state during fasting periods because she's eating up fat stores or metabolizing fat stores. So we have accelerated starvation. Their fat is, again, more readily metabolized whenever they're not eating. So, for example, overnight. And you may start to see some ketones in their urine whenever they come into the office. And this is why you would see them. So what about gestational diabetes? Specifically for gestational diabetes, there is some type of carbohydrate intolerance that has to do with pregnancy for these moms. We don't really know why exactly it happens, but when it does happen, it just unmasks this compensated metabolic abnormality that's going on in the pregnant mom. And we also know that hormones can play a role. We also know that there are certain populations that are more at risk to have diabetes during pregnancy. Native Americans, Asians, and Hispanics are at a greater risk. People who are obese, people who are over 25 years old, which is super young, I know. People who've had a history of really large babies in the past. People who have a family history of diabetes. All of those put you at high risk for actually having gestational diabetes. It's really important to diagnose this because there is a really big increase in perinatal morbidity and mortality associated with gestational diabetes. And like I said in the last slide, many women who end up with this actually progress to type 2 after the pregnancy is over, so they don't really ever overcome it. So let's take a little look at the slide over here, this little picture. So the pancreas is unable to produce enough insulin to counteract hormones that are produced by the placenta. And if we're not able to produce enough of that to counteract those hormones, then we end up with increased sugar levels and gestational diabetes. So, pregnancy can alter our insulin requirements, exactly because of why we just talked about in that slide. And it can accelerate our progress of vascular disease. So we have to be careful with these women in terms of vascular issues. Their diabetes are more difficult to control. Nausea and vomiting can occur, just like it can in people with diabetic ketoacidosis. They may have not great dietary patterns, so we may have to help them from a dietary standpoint, keeping a food diary, making sure they're eating the right things. By the end of pregnancy, insulin requirements for these people might double or even triple because of increased energy needs. Their renal threshold for glucose decreases, and that's why we start seeing this spilling of glucose into their urine. So you'll end up finding that glucose and probably ketones whenever you do your analysis. These people are at an increased risk for ketoacidosis, for hypertension, for neuropathy, and retinopathy. Very similar to just normal diabetes. So what about the mom? What risks do we need to be watching out for in terms of the mother? Well, obviously diet planning. We want to be helping her with that because first of all, if we know that she is at risk for gestational diabetes or she's already got diabetes, if we can get her into some early prenatal care, we can go ahead and get a diet on track. We can make sure that we emphasize she needs really tight control of her blood glucose levels. We can monitor A1Cs. We can get her in the habit of doing those health promotion things the outcome in the end will be much better. Women who have diabetes during pregnancy are at a greater risk for hydramnios. They're at a greater risk for preeclampsia and eclampsia, which are blood pressure problems, ketoacidosis, difficult labors, or dystocia is the nursey word for that. For whatever reason, they sometimes tend not to go through the labor process very easily. From a fetal standpoint, these guys can end up with congenital anomalies. They can grow to be humongous babies. I have delivered a baby one time that weighed over 13 pounds, and the mom was gestational diabetic. That baby did not make it. It was a fetal demise before it ever was delivered. She went to a normal prenatal checkup, and they couldn't find a heartbeat there, so she came over to the hospital, and we ended up doing a C-section. But it all had to do with diabetes. So these babies get humongous. Also, if they have a decent outcome and the babies are alive when they're born, then respiratory distress can end up being a problem. Hyperbilirubinemia and hypocalcemia can be problems for these babies. You're probably looking at this second bullet here under fetal and neonatal risks, the large for gestational age or intrauterine growth restriction, and trying to figure out how can it be both? Well, if you have a mom who is diabetic during pregnancy, we know that the baby eats up all those glucose stores. And so the more and more glucose there is, so more of it that mom can't control, it's readily available for the baby. They take it in and they grow, and they just get too big. However, on the flip side of that, it's also possible for them to have some intrauterine growth restriction, meaning we have some vascular issues that are occurring that aren't allowing the nutrients that the baby needs to get through or to the baby, and that can actually restrict their growth in ways. So they may be really large in size, or if they have this intrauterine growth restriction, they may not be. Or they may be very large and immature in terms of their physical developments, which is one reason why some of them end up in respiratory distress syndrome. So they may be very big, but lungs may not have developed appropriately, that kind of thing. So what do we do? So for moms who have gestational diabetes, this is actually more common than pre-existing diabetes. So it's more common for a pregnant mom to become a gestational diabetic than for her to already be a diabetic when she gets pregnant. Screening obviously is something that we do as a standard part of prenatal care for ladies. It's a laboratory assessment, and then we also work on long-term glucose control if we find a problem. We work with diet therapy. We talk with them about exercise and try to get them to do that, because we all know that can help with high blood sugar. And if we cannot get things controlled in those two manners, these ladies may have to go on insulin if we can't achieve some kind of control. In terms of the baby, if we know that a mom is diabetic already, so she's got a pre-existing condition of that, we might do a quadruple screen at 16 to 20 weeks. And that's part of that maternal serum alpha fetal protein test that I told you that we can do. We will get her to monitor fetal activity on a daily basis, because we know that the fetus has increased risks of not doing well, and we know that fetal activity is the #1 indicator for a mom at home that things are going okay. So we want her to know how to monitor that. Non-stress testing might be something that we do later in pregnancy to make sure that the baby is doing okay And remember, non-stress testing has to do with the fetal heart rate increase in response to activity. So we may bring her to the office every couple of weeks, and during her prenatal appointment, she might have a non-stress test done. Or she may go to the hospital and have it done. And then ultrasounds. So maybe if the non-stress tests aren't turning out real well, and we're not really sure, or we're questionable about those, we may send her actually for an ultrasound or a biophysical profile. We have a whole lot of ways we can evaluate fetal status for these people. Because of the way that diabetes works during pregnancy and the metabolism changes that go on, people who are already insulin dependent diabetics tend to need an increased dose of insulin during pregnancy. But after delivery, it's expected that those people are going to need a reduced dose of that insulin. Your non-insulin dependent diabetics, maybe they ended up having to go on insulin during pregnancy because of how things are metabolized and the way that the maternal system works in relationship to carbohydrate metabolism and hyperinsulinemia and hyperglycemia. But once that person delivers, the non-insulin dependent diabetic who had to go on insulin during pregnancy, they probably also will not need insulin after delivery because their bodies are going to go back to processing things how they did before. So we just pay really close attention to these people and monitor them in the hospital. Your gestational diabetics, they don't need insulin after pregnancy. They may turn into type 2 diabetics. Some of them might. But one thing we might want to do for these women is do a future glucose tolerance test after they deliver to determine that or not. So this slide is talking about oral glucose tolerance testing. And this is the screening test that we do to determine if somebody has gestational diabetes. And we can do it a couple of different ways, and it really just depends on physician preference and how he likes to order it. But we can use a 1 or a 2-step approach. And the 2-step approach is a 1 hour, or the 1-step approach, I'm sorry. Sorry guys, excuse me. Okay, the 2-step approach is a 1 hour oral glucose tolerance test, and we do a 50-gram load on a non-fasting mom. And if that's elevated at 1 hour, then we schedule her for a second test at 3 hours. The 1-step approach is a 75-gram load on a fasting mom, and then we draw the blood at 1 and 2 hours. We're going to talk about both of those. So both of them we perform, both types, the 1 or the 2-step, we do around 24 to 28 weeks. The 1 hour glucose tolerance test, so we're talking about the 2-step approach. We have a 1 hour glucose tolerance test that the mom drinks a 50-gram, looks like that, a 50-gram glucose load, and she will do that non-fasting. Usually it happens in the morning, but she can eat or whatever. Venous sample of blood is drawn, and if it is greater than 140 milligrams per deciliter, then we're going to draw a 3 hour, or we're going to schedule her for a 3 hour. So she'll come back on a different day, and this time she's going to drink 100 grams. And then we're going to draw her blood at 1 hour, 2 hours, and 3 hours. And we're going to see where her glucose level falls at each of those marks, each of those hours. If 2 of those results are abnormal, then we consider her to be a gestational diabetic. So let's go over that one more time. So we're talking about the two-step oral glucose tolerance test. We do this non-fasting, and the first time they get a 50-gram glucose load for the first test. We draw their blood at 1 hour after they drink that nasty little stuff right there, the 50 grams of glucose, and we check to see what their glucose level is. If it's greater than 140 milligrams per deciliter, we order a 3-hour glucose tolerance test. So the physician will get the report back, and maybe it's 148. Well, he's going to call the patient and say, hey, your glucose tolerance test was too high, so we need to do another one, and we need to schedule you to come back on such and such date, and you're going to drink 100 grams this time. So when she's scheduled to come back for the 3-hour one, what we preferably want them to do is eat a diet that's kind of carb full for 3 days before the test. We want her to fast overnight, and then the morning of the test, she drinks the 100 grams of glucose load, and then she comes into the hospital or the lab and has her serum levels drawn at 1 hour, 2 hours, and 3 hours post drinking the 100-gram load. If two of these lab results are abnormal, then we consider her to have gestational diabetes. So what we want is the fasting level to be 95 or lower. We want the 1 hour level to be 180 or lower. We want the 2 hour level to be 155 or lower. We want the 3 hour level to be 140 or lower. So if any of those lab results are above that normal number, if 2 of them are above that number, we consider her to be a gestational diabetic. And all of this stuff is in your book too, y'all. So on the other hand, what about the one step? This one seems so much easier. And probably it's slowly replacing that 2-step. It just depends on the physician. So for the 1-step oral glucose tolerance test, the mom is going to drink this 75 milligram glucose load. She's going to do an overnight fast. She's going to wake up in the morning, drink this glucose load, and then she's going to go to the lab, and she'll have her serum levels drawn at 1 hour and 2 hours post drinking the glucose. We consider her to be gestational diabetic if any one of the following are met or exceeded. So fasting, she's got to be greater than or equal to 92. At 1 hour, she's got to be greater than or equal to 180. And at 2 hours, greater than or equal to 153. So she only has to meet or exceed one of those values for us to consider this particular mom gestational diabetic if she's had the 1-step method. Okay, let's talk about disseminated intravascular coagulation. So, what is it? DIC is it's a problem that is caused in the body system due to another issue. So this does not occur by itself on its own. It happens in response to something else that is wrong. And it can range from very mild to life-threatening. So what is it? It's a disruption of homeostasis that's characterized by a widespread intravascular clotting and bleeding. So intravascular, in the vessels, things are clotting and bleeding. So we've got two completely opposite things going on at the same time. It is a complication of an underlying problem. So if you can't figure out what the underlying problem is, you can't fix the DIC. It can be acute, and that has to be treated immediately, or it can be chronic. And the chronic kind occurs most often in people who have different types of cancers, but most of the time it's characterized mostly by clotting and not particularly the bleeding component. The acute kind, you really see the bleeding component in that one. So here's what happens. There's some type of endothelial damage. For pregnant women, typically it's something like a septic abortion. Sepsis of some kind happens in the pregnant mom. There may be a placental abruption that happens. The mom may have high blood pressure that is complicated by HELP syndrome, which we'll talk about later, and sometimes HELP syndrome will activate disseminated intravascular coagulation. But basically, the body gets confused. So we have some type of damage that occurs or some type of illness, and the body is confused and inappropriately activates a bunch of different clotting cascades. So we have a massive release of thrombin. We know thrombin coagulates things, makes things clot up. And then we have a microvascular occlusion that starts to occur. So we've got all of this thrombin happening, clotting up all of our little red blood cells. And on a microvascular level, those start to occlude your tissues and your organs, and damage starts to occur. So one thing that we start to see is petechiae. If you have little clots that start to happen in the microvasculature of your vasculatory system, one thing that happens is petechiae, and we can see that happening on people. So that's one thing from a nursing standpoint you would assess. And then because we've had this massive thrombin release and things are starting to clot up, the body says, oh my gosh, I've got all these clots that are going on. How am I going to fix that? And we know that our body compensates when it finds something wrong. So our body starts to eat up all these clotting factors. And then we end up hemorrhaging. So there's an accelerated fibrinolysis, which means a breakdown, right? They're breaking down the clots, and the body uses up everything and causes hemorrhage to happen. So let's go through it on this little picture over here. So there's some type of activation of a clotting mechanism, and it's in response to some type of endothelial damage. So we have thrombosis that happens, which means clotting. And then the body says, oh my gosh, I've got some clots. I got to break those down because those aren't good for me. So we have fibrinolysis that occurs. We start breaking the clots down, but the body is using up all of its platelets and its clotting factors because we've got thrombosis going on. And then we start breaking them down. So we're using up all of those things that our body needs. And now we start to hemorrhage because we've used everything up. So here's another, just going through it again in a sequence of what happens. Again, there's some type of endothelial damage. Tissue factors, toxins, and those stimulate a clotting cascade. And it's inappropriate. So the body gets confused and inappropriately starts this clotting cascade. Then there's an excess in thrombin, and that overwhelms our natural anticoagulants. So the things that break down clots, this thrombin overwhelms that. And then we have a widespread clotting that starts to occur in our microvasculature, and you'll start to see petechiae on your patient, right? Petechiae are those little tiny red dots, and that's because they're little teeny clots. Thrombi and emboli impair tissue perfusion, and that leads to ischemia. It leads to death of tissues, right? Necrosis. So if we've clotted up all these little spots in our organs and in our microvasculature, we've impaired the ability of the body to perfuse those places. It's just like having a stroke on a miniature level. So think about it from a tissue standpoint. If we've got clots that are impeding blood flow to certain tissues or organs, they're going to start to die. So you're going to end up with organ damage. So think about your kidneys. You'll start seeing kidney labs get all whacked out. You might see decrease in urine output, or you might see bleeding in the urine output, because we're also going to have some hemorrhaging going on. This can start to affect the brain. It can start to affect the lungs. If all these little microvascular clots happen in your lungs, you're going to start to be able to assess some respiratory problems. Clotting factors and the platelets are starting to become consumed faster than the body can replace them. So on the last slide, when I said we're using them up, the body is using up these clotting factors, using up the platelets, and the body can't replace them as fast as it's using them up. So now, when the clots begin to break down, all the degradation of those things are released, and that causes bleeding. It contributes to that bleeding. Our clotting factors become depleted, the ability to form clots is lost, and then hemorrhage occurs. If we can't clot our blood, then we're going to bleed. These people bleed from everywhere. If they have an IV, they will bleed from the IV. If they have if you have a catheter in them, they will bleed from the catheter site. So they'll bleed from the eyes, you'll see bleeding from the ears, their gums will bleed. They will bleed from everywhere if they have this acute type. So in pregnant people, who is at risk? People who are preeclamptic or have high blood pressure. People who have placental abruptions, and typically the severity of the abruption will correlate with the degree of separation. Pregnant women who have experienced a fetal demise are also at risk for disseminated intravascular coagulation, or DIC, and partly because they're at risk to become septic. People who experience an amniotic fluid embolism, so that's just like a blood clot in the lungs, except it's made of amniotic fluid, or it doesn't have to be in the lungs, it can be anywhere. Septic abortions, and women who have HELP syndrome, and we'll talk about HELP a little bit later. Most commonly, we see DIC in severe cases of sepsis and septic shock. Gram-negative and gram-positive organisms are most commonly associated with DIC from an infection standpoint. Viruses, fungi, parasites can also cause DIC. But remember, DIC doesn't occur by itself. It's a complication of the progression of an underlying illness. So it happens secondary to something else. Again, we see both clotting and bleeding, but the bleeding tends to be more obvious because the clotting happens on a microvasculature level. So if we're talking about the microvasculature level in your lungs or the microvascular level in your kidneys, you're going to see different manifestations of that than you would for a typical like blood clot in the leg. It's not going to be as obvious. You're going to see other system signs that aren't normal. So the bleeding is what draws people's attention because these people, like I said, bleed from everywhere. They'll ooze from their IV sites. They'll bleed from catheter sites. It'll come out their ears, their eyes, especially in acute DIC. And it happens really fast in acute DIC. It will happen over hours, sometimes days, but it's got to be treated immediately. And then again, for chronic ones, it happens a lot more slowly, weeks and months, and usually that one is more prone to the clotting piece and not the bleeding piece. Which is why it's not diagnosed as quickly, because it's sometimes very hard to pick up on those clotting signs because they happen at such a minute level in the microvasculature system. So what are you going to see? Well, here are some things that would stand out for people who come in with DIC or who develop DIC if you're taking care of them. They will be tachycardic. They'll be hypotensive. They're going to have decreased breath sounds, so tachypnea and decreased breath sounds. All those little clots are going to sort of clot up the microvasculature in the lungs, and you're going to end up with that decreased breath sounds. They're going to be confused. They may end up in a coma. They may have some seizures because all of those clots are going to occlude the microvasculature in the central nervous system. They're going to have decreased output, or you may see hematuria because of the microvasculature clots in the kidneys. But also bleeding is happening at the same time. Then you may end up seeing abdominal distension. They may have blood in the stool. You may see GI bleeding. And then again, petechiae. So you may end up seeing those little red spots on their skin. They may bruise very easily. You may end up with all of that oozing from any kind of wounds or orifices that are happening. They're going to be pale because they're bleeding. So this little cartoon says the platelet count is down. And that makes sense because the body is eating up all of the platelets. The INR is up, right? And we know INR is a bleeding time. And he's bleeding from IV sites. Like that would be a telltale sign that your patient is experiencing DIC. Blood testing for DIC is less reliable in pregnant women, and it needs to be conducted sequentially, meaning over and over throughout a period of time. Because we already know that our clotting factors and our platelet counts are sort of disrupted in pregnancy anyway, and DIC disrupts those even further. So sometimes the blood testing for this in pregnant people are less reliable and has to be done over and over and over again during a certain period of time so that you can compare the results against each other over that time period. And DIC affects every system in the body, which is why you see clinical manifestations for almost everywhere. The diagnostic testing that we do in terms of labs, we can do CBCs and platelet counts. We can do coagulation studies. Fibrin degradation products can be tested. Fibrin split products, fibrinogen levels. We can do D-dimers for lung things. And you don't have to know all of those, but the main ones that are super important to be able to recognize are your platelets, your fibrinogen, and your bleeding times. So low platelets, low fibrinogen, a prolonged PT, and a prolonged PTT, right? These are bleeding times. So if they're prolonged, that means the body doesn't clot. So not clotting quickly enough. And if your platelets are low, right? We know platelets help us clot. So if they're low, then the body's going to have a harder time of clotting things up. And then low fibrinogen as well. So how do we manage it? Especially acute DIC can be very difficult to manage, and sometimes the treatment can be controversial and people will disagree on what's the right thing to do. But ultimately, you have to treat the underlying problem, because if you don't, the DIC will only continue to get worse. So if we have a septic abortion and that's what has caused the DIC, we have to fix the septic abortion. We have to give the mom some antibiotics. We have to start treating the bacteria or whatever is causing the infection. If the mom has high blood pressure, HELP syndrome, the only thing we can do for her is to deliver the baby to get that fixed. But we've got to treat the problem that's causing the DIC. But at the same time, we've got an imminent issue to deal with on top of treating that underlying disorder that's causing the problem. So we've got to prevent further bleeding, obviously. So these people might end up with fresh frozen plasma. We might have to give them some platelet concentrates, because number one, that if they're bleeding, their plasma volume is down, so they may need some more plasma. Their platelets are going to be low, so we need to give them some platelets maybe. These people are going to need transfusions probably. Heparin also is a treatment for disseminated intravascular coagulation, and that seems very counterintuitive, because we know heparin actually breaks down clots. And so why are we going to give heparin to somebody who is essentially bleeding out or hemorrhaging? Well, the reason is because if they've got some type of organ damage occurring because of these microvascular clots that are happening, then we are going to have to break them down somehow, and heparin can be done, but can be used. But like I said, treatment can be very controversial. People will disagree what's the right thing and the wrong thing to do. But if you've got organ damage that's starting to occur, heparin may be a form of treatment that has to be used on top of trying to control further bleeding, because we want to try and break down the clots that are causing the organ damage. In really severe forms of DIC, some people have to end up being mechanically ventilated. So they end up having to be on a ventilator for us to even treat the illness. And sometimes this can get so bad so fast that people actually die. The biggest thing that we want to do for people who have DIC is resuscitate the circulatory system so that we can enhance perfusion. So that may be, that's one reason why heparin might end up being an option if people have that organ damage occurring. Supportive care is very important for these people, because it's extremely scary to see a family member lying in bed and they're bleeding from their eyes or they're bleeding from their IV site. These people are very, very sick. These people are managed typically in the critical care unit. We don't have these types of cases on the floor. These people will definitely be in some type of ICU, and our care is going to be focused on assessing the bleeding, preventing any type of further injury to them or to their organs, administering whatever prescribed therapies there are. We want to promote effective tissue perfusion for these people. So we're going to be checking pulses. We're going to be checking the warmth of their skin, looking at cap refill, monitoring their level of consciousness. We are going to need to reposition these people every couple of hours. We don't want these people crossing their legs, or we don't want to elevate their knees on a pillow, because we don't want to occlude blood flow any more than is necessary in any kind of way for these people. We want to minimize the use of tape on their skin. So if you pull tape off, these people are going to bleed from that. So we have to be very careful, even for things as simple as taking IV tape off and replacing an IV. We are going to have to monitor gas exchange, because these people will have an impaired gas exchange because of, number one, they're bleeding and they're losing the ability to carry oxygen, and they've got clots in their microvasculature, probably in the respiratory system. So they've got an impaired gas exchange in a couple of different ways. We want to monitor their O2 sats continuously. We might have to put these people in a high Fowler's position in bed so that they can breathe easier. We want to make sure they stay on bed rest, encourage them to deep breathe and cough as effectively as possible. They may need an incentive spirometer. We might have to suction these people out, especially if we've got some gastrointestinal bleeding that's going on. But that would be something that we would want to be extremely careful to do, because if we're having to suction someone out, we don't want to create another place that they can bleed from. So we'd have to do that with extreme caution. We want to give them pain medicine if they need it, and anti-anxiety drugs if they need that. Sometimes we have to be an advocate. Sometimes the physicians don't think about that for people who are in situations like this, very scary situations. They don't realize maybe from a psychological standpoint how it affects that patient. Not that they don't know it does, but they're just not there as often as you are. So you as the nurse see things at the bedside that the physician may not have the opportunity to see. You may have to call and get pain meds ordered. You may have to call and get some anti-anxiety ordered, some sleep medications ordered. And also managing pain for these people and identifying where that pain is coming from is key. Because if we've got clots in different places all around the body, we want to know, first of all, where is the pain coming from, and is it potentially due to some clots that are occluding things that aren't being oxygenated, and is that a first sign of something else that it's impending? We want to handle them very carefully. So when we're moving them, changing their position every couple of hours, if they're getting bed baths, their extremities have to be handled very gently. We don't want to be banging their arms up against the side rail because that's going to cause more bleeding. Sometimes applying cool compresses to their painful joints also is helpful, but again, you got to have an order for that. The biggest thing that we want to prevent are complications related to DIC. We want to make sure that we can prevent any end organ damage that they're going to carry with them for the rest of their life. So trying to manage this, trying to identify it quickly and manage it quickly will decrease the risk that they'll end up with organ damage that they'll have to live with for the rest of their life. We want to make sure that we can help their families cope. We want to make sure that we control their bleeding. And we want to make sure that their body systems will actually be able to meet the needs of oxygenating, and perfusing itself on all levels to prevent as much tissue damage and organ damage as possible. So a very confusing sort of secondary illness, I know. My suggestion is to read your book, to listen to the PowerPoint, and maybe do some research and some Googling on your own to try to find some reading that will help you maybe make sense of this if it still feels confusing to you. ATI should help as well. And that's it. I think I'm going to stop this PowerPoint here and pick up again with hypertensive disorders of pregnancy in another video. Thanks for listening.